Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will discuss about the trochlear nerve and its applied aspects. So the trochlear nerve is the fourth paired cranial nerve. It is the smallest cranial nerve and has only the somatic supply to the superior oblique muscle. If you come to the anatomical division of the fourth nerve, it has the nuclear part, vesicular part, trunk or which runs in the subarachnoid space, intracavernous part and the intraorbital part. So this is the overall view of the fourth cranial nerve. As you can see here, this is the nucleus of the fourth cranial nerve which is situated in the pons. Then we have the vesicular part which will run in the brainstem. Then it comes to the subarachnoid space and then into the cavernous sinus, and then through the superior oblique fissure it will enter into the orbit and then supplies the superior oblique muscle. This is one more picture which will show the complete view of the fourth cranial nerve. So it has the nucleus in the dorsal part of the brainstem, and then we have the vesicular part, then it has the subarachnoid part and then in the cavernous sinus and then enters the orbit and supply the superior oblique muscle. So coming to the nucleus of the fourth cranial nerve, the nucleus is located at the level of the inferior colliculus as you can see in this picture. As you can see in this picture, we have the sylvian aqueduct here. So the nucleus is located ventral to the sylvian aqueduct, and then it will have its vesicular part. If you come to the relations of the nucleus with other structures, we have the medial longitudinal fasciculus which is located inferior-lateral to the trochlear nerve nucleus. So the isolated nuclear palsy is very unusual. The nuclear lesions will usually lead to contralateral fourth nerve. As you can see, the vesicular part will run and then it will completely decussate and goes to the contralateral superior oblique muscle. If the lesion is at the level of the nucleus, it has to affect the contralateral superior oblique muscle. The causes for nuclear lesions are like vascular diseases, trauma or the demyelinating diseases. Coming to the vesicular part, so the axons from the nucleus will curve posteriorly and then decussate completely to the other side of the brainstem in the anterior medullary velum. Anterior medullary velum is nothing but the thin membrane which is covering the roof of the fourth ventricle. Nerve will decussate completely in the anterior medullary velum. If you come to the causes of vesicular lesions of the fourth cranial nerve, it is usually secondary to the vascular lesions or secondary to demyelinating diseases. Coming to trunk or the subarachnoid course of the fourth nerve. So as you can see in this picture, the nerve leaves the brainstem on the dorsal surface just caudal to the inferior colliculus and then curves laterally around the brainstem and runs forward beneath the free edge of the tentorium. Then it pierces the dura and then enters the cavernous sinus. So you can appreciate very well in this picture. So the nerve has come on the dorsal surface of the brainstem and then it is curving laterally along the free edge of the tentorium. Okay, and then it pierces the dura and enters the cavernous sinus. So because of this long course within the subarachnoid space, the peripheral trochlear nerve is subjected to damage from the closed head injuries due to counterhook forces, which is transmitted to the brainstem by the free tentorial edge. So the causes for trochlear nerve palsy at the level of the subarachnoid space are secondary to ischemic injury, secondary to diabetes, which is more common cause of fourth nerve palsy, or it can also happen secondary to hydrocephalus, vascular loops or the tumors, which can lead to pressure effect over the tentorium cerebelli. If you have bilateral traumatic fourth nerve lesion, it is usually at the level of the anterior medullary velum where the nerve emerges together. Okay. Next, moving on to intracavernous part. Here the nerve runs in the lateral wall of the cavernous sinus, inferior to third cranial nerve and just above the first division of the fifth cranial nerve. So here we have the fourth cranial nerve. Okay. And in the anterior part of the cavernous sinus, it rises and passes through the superior orbital fissure above and lateral to the annulus of Zinn. If you look into the cranial nerves which are supplying the extraocular muscle, the fourth cranial nerve is the only nerve which will come above the annulus of Zinn. It will not enter into the annulus of Zinn, and that is the reason the nerve may not be completely paralyzed when you give the retrobulbar block. Next, moving on to intraorbital part. So as I told, the nerve will enter through the superior oblique fissure above the annulus of Zinn and then it will supply the superior oblique muscle. And we have so many specialities about the trochlear nerve. So this can be asked in your viva or in your MCQs for your entrance exams. So this is the smallest cranial nerve. It has the longest intracranial course, the thinnest cranial nerve, only cranial nerve to emerge posteriorly from the brain, has the smallest vesicular course, only cranial nerve takes it dorsally and completely. Among all the nerves which supply the extraocular muscles, this is the only nerve which will enter through the superior orbital fissure outside the annulus of Zen. It is not affected by moderate amount of retrobulbar anesthesia. So hope this short video on trochlear nerve and its applied aspects is helpful to all of you. If you like my videos, please do subscribe to my channel. Press the bell icon for further notification. Please do like and share my videos. Thank you so much.